Thank you everyone for joining. Today we have a greatest pleasure to host Antonio F. Corno, Tony, who is originally from Italy and now working in Children's Memorial Hermann Hospital as a research professor. He is otherwise a congenital cardiac surgeon and we have been working very closely for many years, and he's a really good friend of mine. So I was looking forward to host him, and I hope that you will enjoy his presentation.
Thank you so much, Miriana. Good morning or good afternoon, everybody. Can you hear me? Yes?
Yes.
Great. Good afternoon, everybody. The main reason behind this title of Brain and Congenital Heart Defects is simply the fact that in the last couple of decades, the mortality for pediatric heart surgery decreased dramatically. So all the focus of the caregivers, families, society moved from the survival to the quality of life. And of course, the brain is the most important factors in the quality of life. This slide has been given to me by Bill Gaynor, pediatric heart surgeon from Philadelphia, who for the last 40 years has studied all the potential factors involved in the brain damage or brain development from the real beginning, which is the conception, then through the fetal life, birth, and the period after birth, including surgery, hospitalization, and so forth. And every year is giving a talk on this topic, and every year is adding a new factor. The last one discovered was the negative effect on the brain of anesthetic agents and plasticizers of the tubing. But to talk about all these factors probably will take a couple of weeks. So I will focus this talk on the period of the fetal life, with particular reference to the reduced coronary blood flow and therefore oxygen delivery, the abnormal maternal fetal environment, and so forth. If you remember your medical book, or you still have it handy, that is the representation of the placenta, which, as you can see, is very well vascularized and is, of course, a vital organ because it's the only organ providing nutrition and the growth for the fetus. This group of Philadelphia studied the ratio between the body weight and the weight of the placenta and the other way around, placenta over the body weight, which is represented here in the normal patient population, 7.1 or 0.20, and they measure in 120 subjects divided in 4 groups. Group 1 is single ventricle, 1V, with aortic or systemic obstruction. Group 2, 1 ventricle with pulmonary obstruction. Group 3, 2 ventricle. Group 4, transposition of the great arteries. And they measure in all the group the ratio between the body weight and the placenta weight, and the other way around, placenta weight versus the body weight. And as you can see, they are all significantly abnormal. So kids with congenital heart defect, whatever is the type of congenital defect, have an abnormal placental growth. Here, the same group plotted through the gestational age, the normal weight of the placenta towards the body weight during the last weeks of the gestational age. The red line is the average, and the red dot is 1 standard deviation. And you can see in the blue one is the average weight of the placenta in kids with congenital defects. And the average is already 1 standard deviation lower than the normal kid. And therefore, again, the kids with congenital defects are having an abnormal development of the placenta. This is a study done in Cincinnati with the histology of the placenta comparing the control group, no congenital defect, where you can see a very diffuse and wide vascularization, with the placenta of kids born with apoplastic left heart syndrome, where you can see the vascularization is reduced, and there are also deposits of fibrin, which are totally absent in the normal heart. So what's happened? If you have an abnormal placenta and in the same time a fetus with congenital defect, they two help each other to have an abnormal growth and functioning of the placenta. Therefore, you have an impaired transfer of nutrition, flow, and oxygen from the placenta to the fetus. Sometimes you can have compensation mechanism, sometimes not. You have therefore a diminished growth of the fetus and a suboptimal weight at birth, and this we know is correlated with adverse clinical and surgical outcomes. The same group again compare control cases, that mean no congenital defects with hypoplastic left heart, and in all of them, excuse me, there was a reduction of the body weight compared to the control at birth and of the placenta weight, and the significant was statistical important. This group of Catherine Limperopoulos, who is an authority in the field and is working in the Children's Hospital of Washington, D.C., has studied the placenta in patients with congenital defect. And she compared the group with and without and with aortic obstruction, and you see a quite disturbing incidence, 40% to 40 to 83% of pathologies of the placenta in kids with congenital defect, very high in presence of aortic obstruction, but almost 50%, even in absence of systemic obstruction. The same disturbing percentage, higher than 50%, was present in kids in fetuses with single ventricle physiology. This is a very sophisticated study done in Cincinnati on a map of RNA sequencing profile. These are the control group. These are the group with transposition. Even a surgeon can see the transposition are not absolutely normal, but at least the color remain almost the same. Terribly abnormal are the RNA sequencing profile in apoplastic left heart. And we see immediately then the reason is that in patients with transposition of great arteries, there is a reduction in the oxygen saturation, while in apoplastic left heart, there is a reduction in oxygen saturation and a reduction in the systemic flow. Now, this group made this study, try to see if it was possible to have an answer, if there is a cause between the abnormalities of the placenta and the congenital heart defect, if these abnormality of congenital heart defects are a consequence or simply if there is a correlation between the two. And based on the study, they concluded that at the moment it's impossible to say if it's egg and chicken problem, is the placenta the cause or the consequence, or there is a correlation in human beings. But from the studies they have done in mice and chickens, so different animal species, it seems then the abnormality of the placenta is contributed to, through the vascular changes, to the poor development of the brain in congenital heart defect. And this is the mechanism in a study published a month ago, again by the group of Catherine Limperopoulos in Washington Children's Hospital. Then the excuse me, presence of congenital heart defect, particularly in hypoplastic left heart transposition and single ventricle physiology, is sending to the placenta a very hypoxemic blood, and this is causing placenta insufficiency, which in reverse is transmitting a poor perfusion of nutrition, oxygen, and so forth to the heart, so is a lose-lose situation. This is again an example of the normal fetus and normal placenta adjusted for the gestational age. And you see then when there is a congenital heart defect, instead of being normal, the growth of the placenta is impaired and it doesn't have the growth of the normal fetus. This is again a sophisticated study done by Catherine Limperopoulos and her group, showing with the MRI then the insertion point of the cord of the placenta is absolutely central, with a very symmetric growth of the placenta around. In the presence of congenital heart defect, the insertion of the chordal placenta is not in the center, but is in a wrong position, and this is causing an asymmetrical growth of the placenta. So it's not only the size of the placenta, but also the shape of the placenta that is abnormal in the presence of congenital defect. Now we move to the brain. Again, if you remember your book of medical school, the brain in section has a gray matter, a white matter, and in the middle there are the ventricles. Gray and white matter are both essential but completely different. The gray matter is more organized with nuclei, while the white matter in conduction element. So therefore here in the gray matter is the production of the cerebral activity, while here there is the transmission. Another important characteristic of the gray matter is that the surface of the brain is not smooth, but there are the convexity and concavity called gyri, plural of gyrus, and sulci, plural of sulcus. Sulcus is the concavity, and gyrus is the convexity. And then we will see shortly why these are so important, because they give a tremendous surface area compared to the mass volume of the brain. Why the white matter then is devoted to the communication, not to the production of activity, is so important. First, the heart is the first organ to form during embryonic development. Therefore, there is a great overlap time between the development of the heart and the brain. Basically, since after 7 weeks of gestation, the heart is fully developed, the presence of congenital defect can disrupt the fetal cerebral oxygen and nutrient delivery for a period very long, 7 months, which is a period very important for the development of the brain. And by the way, clinical study, and this has been done by the colleague in Washington, D.C., has shown that the white matter lesion in patients with severe congenital defect are quite similar to the same MRI study showing damages in the white matter in preterm babies. In the grown-up adolescent has been found a strong correlation between their cognitive behavior and outcome and the diffusion tension MRI imaging of the white matter. Therefore, the white matter is very important for the neural connectivity and communication. And by chance, again, the same group found that there was a strict correlation between the presence of immaturity and damage due to various causes of injury and the severity of neurological deficit exhibited in congenital defect patients. This is a very simple explanation of what happened during the fetal life. In the normal fetal circulation, you have the oxygenated blood coming from the placenta, going through the inferior vena cava right atrium, through the patent foramen ovale into the left heart and perfusing the brain. In presence of hypoplastic left heart, the oxygenated blood cannot go through the patent foramen ovale because the left heart is underdeveloped, so it goes into the pulmonary artery, through the patent ductus arteriosus, retrograde to the brain. So the brain is receiving a reduced amount of blood flow with low saturation. So you have two causes for brain damage in apoplastic left heart syndrome. One is the reduced saturation, one is the reduced flow. And as we know, then the oxygen delivery depends from the output times the oxygen saturation times the level of hemoglobin over hematocrit. You have a severe damage of the brain in fetal life of apoplastic left heart syndrome. This study again has been done by the colleague in Washington, analyzing with MRI or diffusion tension MRI, the brain of fetuses and neonates, but we look only at the fetuses and we see that if we consider the hypoplastic left heart syndrome, 1 child over 2 at birth, so before any cardiology or cardiosurgery intervention, has severe white matter injury, and in the group of transposition or single ventricle physiology, this incidence is reduced, but still one child over four has at birth already MRI evidence of white matter injuries. Here is again a repetition of the explanation of the cause. In the normal heart, from the placenta, you have a blood with 65% saturation going into the ascending aorta and reaching the brain. In presence of transposition, you have a reduction of the oxygen saturation going into the blood going into the aorta to the brain, but still there is a normal blood flow. In hypoplastic left heart syndrome, you have a less important reduction of the saturation, but since the brain is perfused for retrograde fashion through the pattern due to sartoriosus hypoplastic heart, you have a reduction of the blood flow to the brain. And these are the long-term consequences of neurological impairment presented by Gil Vernosky. At the time he was working in CHOP, Philadelphia, before moving to Washington. Then the severity of congenital heart defect, if you plot it here, is in proportion to the neurological impairment from mild to severe, becomes even more frequent, the neurological brain, if you have a complex congenital heart defect, and this neurological damage becomes almost present in all of them if you have a complex congenital defect and a presence of a chromosome abnormalities. This is to talk about the Giri and Solkisi as we anticipated before. The surface of the brain is quite smooth at the beginning of or middle of the fetal life, and in a term infant is not smooth anymore because of Giri and Solkisi. If you talk to a mathematician or bioengineer and they plot this convexity and concavity on a flat surface, you have an homogeneous distribution of the distances and so forth. It's totally different if you plot them on a ball or sphere surface or a source of cone concavity, like most of the areas of the surface of the brain. And then you can obtain a different proportion of short to long connection to transmit the neurological stimuli. And that's why the development of convexity and concavity is very important in the surface of the brain to have a normal function. Here, again, the group of Washington has studied the component of the brain, frontal, parietal, occipital, and temporal, in the prenatal life, postnatal life with MRI, and they measure the gyrification index, so the ratio between convexity and concavity. In normal subjects, no congenital defect are the black dots, versus the hypoplastic left heart syndrome, the empty dots. And you can see then they start more or less the same. But during the progression of the fetal life, the difference between hypoplastic left heart syndrome and control becomes very important and reach significantly before birth or the moment of birth in both the groups of hypoplastic left heart syndrome versus the control group. They studied with sophisticated MRI study human fetuses, and in the human fetuses, they evaluate with very sophisticated measuring the subventricular zone of the white matter. And very simple, if you look at this imaging, here you have the normal fetuses of human being compared to the fetuses with congenital heart defect. And you see immediately there is a poor development of the subventricular zone of the white matter. The same in this other study, even more different in human fetuses between normal subject and very complex congenital defect. To prove the cause-effect association, they've done this study on piglets, putting the piglet on bypass for a period of 2 weeks on chronic hypoxia. And they made a comparison between the normal level of oxemia towards the hypoxic piglet. And again, you see the huge difference between the development of the subventricular zone of the white matter in piglet exposed to hypoxia. This group of Portland has summarized very well the difference of the brain development and therefore the cognitive function in normal kids with healthy condition when during the fetal life the brain is exposed to normal cerebral blood flow and normal level of oxygen saturation, and you have a normal development of the brain and a normal cognitive function. In the group, instead, with the presence of severe congenital defect, you have the association of reduced cerebral blood flow and or reduced cerebral oxygenation. Going back to the formula of before, oxygen delivery is due to output, saturation, and hemoglobin, and therefore you have the combination of the two. You have, during the fetal life, a poor oxygen delivery to the brain. The final result is poor brain development with, as a consequence, cognitive impairment. This study has been done in the Imperial College in London, where our chairman is now, and again observing only the fetal, forget about postnatal or postoperative, fetal normal human beings, they have a very disturbing incidence of presence of reduced volume of the brain and damage to the cortical brain matter, mostly present in hypoplastic left heart syndrome, but also as expected in single ventricle physiology, transposition, arch defect, and some patients also with coarctation. About to talk the reduced blood flow to the brain when he is perfused in reticular fashion from the PDA. Similar results have been observed in this group in Imperial College in London. They have done a literature review, again comparing fetus and neonates with single ventricle physiology and transposition of the great arteries, and you see about half or less than half show no injury to the white matter or a percentage of injury or even infarction in a reduced number, but still almost one kid every two of fetus had white matter injury. This, to please our chairman, who is from Denmark, is a study done in Aarhus, Denmark, where they show the difference between the control group and the patient with major congenital defect in terms of cerebral size. And you can see that with the progress of the pregnancy, the development of the brain is impaired in presence of congenital defect. And of course, it's quite evident when you have a low oxygen saturation like univentricular heart or tetralogy of Fallot. At this point, it's okay. Quite evident then it's important to study the brain during the fetal life, and the best study published are from the group of sick kids of Toronto, where all the kids with congenital defect are undergoing a cerebral and heart MRI before surgery, and they can evaluate the presence and flow through the umbilical vein, umbilical artery, ascending aorta, main pulmonary artery, and superior vena cava. And I measure the combined ventricular output and umbilical vein flow in normal subjects, not congenital defect, patient with a biventricular anatomy, no major difference, and patient or not statistically different, and patient with single ventricle physiology, and you see the combined ventricular output and umbilical vein flow is reduced in the presence of single ventricle physiology. They have compared 30 patients with normal heart and 30 fetuses, sorry, with normal heart and 30 fetuses with congenital defect. They have found a significant reduction of the volume of the brain in congenital defect. The ascending aorta saturation was lower, the umbilical vein saturation was lower, and as a consequence, the oxygen consumption of the brain was lower in patients with congenital defect. With their sophisticated MRI, they measure again the ratio of the volume of the brain compared to the volume of the fetus. They measure very well. This is an example of a patient with total anomalous pulmonary venous connection in the fetus, where they measure the flow in the aortic valve, pulmonary artery, PDA, descending aorta, umbilical vein. Very complete study of the circulation. This is the 3D reconstruction of 20 weeks gestational age in a normal fetus, and this is a fetus with a ventricular setup defect, and this with aortic coarctation, so they repeat the same measurement in the presence of congenital defect. And this is a study done by one of their PhD, Jesse, comparing the transposition who had surgery early, less than 2 weeks, and late, more than 2 weeks. But forget about surgery and arterial switch now. Look at the preoperative MRI evaluation. Only a bit more than 50% of the patient with transposition of the great arteries, we're talking about transposition, not apoplastic left heart, had the normal preoperative cerebral MRI. Wide matter injury were present in this percentage, as you see, from mild to moderate severe, and also stroke and intraventricular hemorrhage. So almost 1 every 2 kids born with transposition of of the great arteries is having had the fetal MRI already brain injury present. And this has been again confirmed in a combined study between Utrecht in Holland and Sick Kids in Toronto, where they have done preoperative MRI in 100 patients with congenital defect, all undergone surgery in 2 months. That means it was severe lesions, and we'll see them. And they found multiple lesion, wide matter lesion, stroke of the middle cerebral artery, and also stroke in other area of the brain. This is the patient distribution between the hospital in Holland and in Toronto, Canada. And you see single ventricle with aortic obstruction, transposition interception, transposition VSD, transposition aortic obstruction, and so forth. The distribution is a bit different, but basically is more or less overlapping. And you have 100 patients with MRI, cerebral MRI done before surgery, and you can see in the 2 hospitals, there was a very disturbing percentage of ischemic injury, multifocal injury, any type of injury in the brain. Now, at this point, it's quite evident that we know that if there is a prenatal diagnosis of congenital heart defect, particularly if it's a transposition of the great arteries, a single ventricle physiology, or even worse, apoplastic left heart syndrome, we have to expect that at birth there will be 50% or a bit less for the other lesion of brain damage already present. The obvious question at this point is, what can we do, or can we do anything to prevent or reduce the brain damage occurring during the fetal life when we have a congenital defect? And in the next slides, I'll try to show you what has been done or studied at the moment. This group, again, of sick kids has studied this type of procedure. You have a prenatal diagnosis of hypoplastic left heart versus normal control, no congenital defect. In this group, there is an unrestricted pulmonary venous drainage. In this group, there is a high resistance drainage from the left atrium because the interatrial communication is restrictive. What they have done, during the fetal life, they did a balloon septostomy and stent of the atrial communication. And you can see here in these 3 patients, the mean result of the cardiac output and the percentage of the cardiac output going to the brain, cerebral flow, before and after the stent. And very important is to see that they managed to grow both the cardiac output and the percentage delivered of blood flow delivered to the brain. And these numbers are remarkably similar to the normal subject. You see, almost identical. Normal subject without congenital defect. So doing a balloon cestostomy during the fetal life and placing a stent and decompressing the pulmonary venous drainage can improve the perfusion and oxygenation of the brain as in a normal child, and much better, significantly better than in fetuses with hypoplastic left heart syndrome without obstruction to the pulmonary venous drainage. That's one way. The same has been done in this fetus with a quite severe damage of the lung with lymphangiectasis. And you can see after 11 weeks of balloon dilatation of the patent foramen ovale and atrial stenting, the lungs are growing quite normally. This is a child with prenatal diagnosis of right ventricular tumor, rhabdomyoma, very big, compressing the left ventricle and reducing the left ventricular filling. And you see here, after a treatment with sirolimus, which is an immunodepressing medication used in transplant, particularly in kidney transplant, the filling of the left ventricle became normal. This is again a prenatal diagnosis of severe Epstein anomaly in a fetus where you have the circular shunt because of the severe tricuspid valve regurgitation. All the blood is going from the right atrium through the foramen ovale into the right ventricle. Excuse me, the blood goes in the aorta and comes back to the patent ductus arteriosus. So there is a circular shunt. And this shunt through the large patent ductus arteriosus is creating a stealing of oxygenated blood from the brain. So the brain is receiving a reduced flow of oxygenated blood. This case has been treated, given to the mother indomethacin to constrict the ductus arteriosus for a week. And the result was a significant increase, 1 week difference before and after treatment in the superior vena cava flow, descending aorta umbilical flow, and more important, the ductal reverse flow, because the circular shunt has been dramatically reduced from 42% to 10%, so the PDA was still patent, but reduced flow, and this has substantially increased the oxygen delivery to the brain as a consequence of the oxygen consumption from the brain. More important is the matter of maternal hyperoxygenation, consisting in this. Once the pediatric cardiologists do a fetal diagnosis of complex congenital defects, the mother is admitted to the hospital and is hospitalized till delivery with oxygen administration to improve her oxygen delivery to the fetus through her placenta. This is an example of a study done with maternal hyperoxygenation in normal subjects, where the flow through the patent ductus arteriosus had been increased by having hyperoxygenation. And this is in presence of congenital heart defect, where the maternal oxygenation, yes, has increased the blood flow through the patent ductus arteriosus, but also through the umbilical vein in the fetus and to the descending aorta. If you compare the effect here of maternal oxygenation in red, in blue, the normal subject, and in red, in subject with congenital defect, you see the dramatic effect in improving the umbilical vein and descending aorta flow thanks to maternal oxygenation. These are the effects of maternal oxygenation in kids with aneurysm of the interatrial septum, where the pressure in the right atrium is pushing the aneurysm towards the left atrium because there is a reduced filling of the left atrium and therefore of the left ventricle. And these are the numbers before and after maternal oxygenation. You see the atrial septal excursion index measured with echo is reduced. That means the aneurysm is less pushed towards the left atrium. Therefore, the filling of the left atrium is improved, and therefore the filling of the left ventricle, as you can see here. And more important, the direction of the flow through the aortic isthmus from retrograde becomes antegrade in almost all of them. Corresponding images are here, where you have the flow through the ductus arteriosus and the transverse aortic arch. And as you can see here in baseline room air, you have all more reverse flow to the transverse arch and becomes positive flow after the maternal oxygenation. So by doing a literature review of maternal oxygenation, we can definitely know then it's increasing the pulmonary blood flow, the pulmonary venous return, and therefore the filling of the ventricle is reducing the flow to the pattern ductus arteriosus and therefore improving and increasing the dimension of the left heart. Therefore, maternal hyperoxygenation can be used as a diagnostic tool and also therapeutic tool in fetuses with congenital disease. This is an article published a month ago, or in December, with an extensive literature review of the effects of maternal reoxygenation. Many articles are very recent, and you can see that has been done in acute or chronic way and in different protocol with minimal variability, but the goals were to improve the size of the left heart cavity and the cerebrovascular response. This is a list of centers in North America, mostly United States, doing a source of clinical trial with maternal hyperoxygenation in congenital heart defect, mostly with hypoplastic left heart syndrome or cyanotic disease. And this is what we hope to obtain then from having a prenatal diagnosis of severely hypoplastic left heart, where you can go only towards a Fontan procedure. You can improve the feeling of the left ventricle, obtain a borderline left ventricle, where after birth you can do in stages surgical procedure to avoid the pathway towards the Fontan. Everybody knows that the late outcomes of Fontan procedure can be a nightmare. Or even better, if you develop the ventricle enough, you can go towards a biventricular repair. These were clinical studies. These are experimental studies done mostly in Philadelphia and Washington by the colleagues. And this is a ex utero ship model where is virtually a ECMO for a ship during the fetal life. That's quite sophisticated model. They compare for animals normoxis and hypoxis. Everything is absolutely equal or identical. The only difference was the oxygen delivery. In normoxis was normal and reduced significantly in the hypoxic group. These are the results observed in the fetal ship study, comparing the control, all the various neurological evaluation done with MRI. You can see the control group, that means no ECMO if you want, or abnormal artificial perfusion, and the results were quite similar in the normoxin group for all these evaluation, while severe derangement have been found in all the neurological evaluation in the hypoxic group. So that means hypoxia in the fetal life definitely is not very positive. The same, they have done study on cytoplasmic process in the brain. And once again, if you look at the control group, normoxic group, and hypoxic group, you have in the control group a percentage then is quite similar to the normoxic group, even is a bit less because of the artificial perfusion. Severe damages 1/3 animals in the hypoxic group. Then they did something very interesting with their model of fetal ship perfusion in normoxic and hypoxic group through the umbilical cannulation. They treated the hypoxic group with infusion of substrate. That means they made them hypoxic and then they gave something. And this magic something is simply glucose, dextrose. So they treated hypoxic animal by giving only glucose dextrose. Anyone can do that. And here you see the cerebrovascular response to oxygen and substrate delivery. You have this difference between hypoxic and normoxic, and everything becomes completely mixed, and you move from the fetal oxygen delivery significantly impaired to a virtual no significant difference between hypoxic and normoxic, simply giving through the umbilical access delivery of glucose, of dextrose. The analysis of this study was that the presence of hypoxic or hypoxemic perfusion through the heart during the fetal life can cause a decreased resistance to the middle cerebral artery in the brain, and therefore this is causing inadequate compensation and dysmaturity of the brain. This is a very interesting study by the group of the colleagues in Washington with Richard Jonas, where they studied the effect of the tetrahydrobiopterin, very difficult name, basically is a cofactor for the activation of the neuronal nitric oxide synthase. In absence of this element in the brain or in the body, you have a reactive oxygen species that starting and activating the process of cellular apoptosis and necrosis. So to an animal model of rodent, mice, they compare the weak gestation of the human being with the rodent treated with 3 weeks of severe hypoxia, FiO2 10%, 10.5%, and the same treated with the administration BH4. And these were the result of the study. They found then in the group with hypoxia, excuse me, there was no change in the BH4 level in the heart, but a significantly different distribution of BH4 in the brain. That means the presence of hypoxia is not causing damage in the fetal life to the heart in this experimental study in mice, but is causing severe damages into the brain. And these are the effects of the administration of this BH4 in various elements of the brain, where you can see the effect of the presence, sorry, of BH4 in the normoxin group. This is the gray is the severely hypoxic group, and then the reduction of the damage induced by BH4, which is almost moving the various elements of the brain to the same level of the normoxic group and reducing a lot, substantially, significantly, the damage induced by hypoxia. This is a study done by a group again in London Imperial College, where have been evaluated the effect on the brain to protect the brain from the hypoxic ischemic injury in experimental study in mice. Again, studying the embryonic stem cell derived mesenchymal stem cells. And they have seen a reduction, as you can see here again, black, gray, white are the control of the damage in the brain by simply administering mesenchymal stem cells. This study has been used by the group in Washington, and these slides are a courtesy from Richard Jonas, where they start to study this mesenchymal stem cell administration to see if they were well distributed in the body in animals, in piglets in this case. They have followed this and they have seen there was an equal distribution between the brain, the heart, and the kidneys. And here they calculated the various distribution to the organs. That means administering mesenchymal stem cell to the body, they were going everywhere. And of course, they wanted to target the brain. So what they have done, they have studied with specific distribution to the neck vessel, to the brain, and they have seen then there was equal distribution between the right and the left part of the brain, normal mice, no congenital heart defect. They have done this study, again, exposing the animal to hypoxia, of course, to put them on cardiopulmonary bypass. They move from mice to piglets because they are 3 kilograms like a neonate. And again, you have here the control group. The green is the hypoxic group on cardiopulmonary bypass hypoxia. And this is on the same cardiopulmonary bypass technique with administration of mesenchymal stem cell. And you can see all the neurological evaluation. Again, the administration of mesenchymal stem cell has reduced dramatically all the damages induced by hypoxic cardiopulmonary bypass for 2 weeks, and brought back to the values to the normal. Before moving to a clinical trial in patients, of course, they have to persuade the FDA that this was feasible. So they had to study in the animal model. There were no sign of neurological damage or no other ischemic damage, intraventricular hemorrhage, and so forth. And look, all the parameters, then they have been monitored in the piglets pre-bypass, so beginning, baseline, post-bypass, and 3 hours bypass. And you see all the parameters. I'm sure the intensivist will be surprised because probably we do not measure all these parameters, even if most of them in our patient in pediatric ICU. So they proposed this study to see if the administration of mesenchymal stem cell can reduce the injury during cardiopulmonary bypass. And this is the initial protocol for the trial, clinical trial beginning. To delivery mesenchymal stem cell through the arterial system. I'm sure you recognize here a Norwood procedure with the Sano-shunt. That's the reconstruction of the descending aorta and aortic arch. These are the pulmonary artery, and this is the finish of the anastomosis of the conduit from the right ventricle to the pulmonary artery with the Sano modification. And at this point, before coming off bypass, that is a clinical trial recently started. The mesenchymal stem cell are administered in ascending aorta to perfuse the brain. Of course, we are all curious to see how will be the result of this clinical trial. And this is the last slide to remember you that is very important not to forget the brain, even if we are focused on the heart, because we have seen then with the prenatal diagnosis of heart and brain, once we have a congenital defect, the fetus has high chances and at birth will have severe brain damage, particularly in 3 groups of patients: transposition of the great arteries and single ventricle physiology because of low oxygen saturation, and hypoplastic left heart or arch abnormalities, coarctation, hypoplastic arch, interruption of the aortic arch, because of the combination of low oxygen saturation and low perfusion of the brain. Thank you very much for your kind attention.
Thank you so much for this brilliant presentation. I enjoyed it a lot.